sure you check on Blackboard, the learning module section, to see what time to show up at, and who your partner is. So the second one here, I'm going to ask you to perform all active and passive ranges of motion on your partner's ankle. Okay? So essentially, what four motions are there in the ankle?
Eversion, inversion, flexion, extension.
Exactly. You guys all got it, hopefully. I can't really differentiate. So, right, one of the things is knowing that you have those four motions to test.
Right.
So I want you to name those four motions as you're doing it and obviously get that motion right. Right? If you go up, bring your foot up, and you call that plantar flexion, that's not going to be correct. Cool?
Cool.
Yeah. Also, for the test, I want you to do it by the book, right? We're going to go by the textbook. First, at least in your first test you've ever had on this stuff, I don't want you to do the deviated version of it, which means that I want you to do each of these against gravity, right? So dorsiflexion, active range of motion, is going to be up like this. But is plantar flexion going to be down?
No.
No.
He has
Right.
to be
You're
on
going to
his
have to
belly.
start spinning them around, okay? So then you can just say, bring your foot up. Okay, relax. Can you turn on towards your right side, my left side? Yep. Perfect. You can just head up like this. So bring the outside of your foot up to the roof. See, that's eversion. Now can you go on your stomach, please? Bend your foot up. Bend your foot up like this. Yep. Now bring your foot to the roof. That's plantar flexion. See that? And then finish your roll out.
So you're going to test the first thing.
And then coming up. And that's going to be testing inversion, active range of motion against gravity. Does that make sense?
Yeah. And you only
Cool.
need us to do one foot. We don't need to do it bilaterally.
I would like you to state it bilaterally, because in real life you would do it bilaterally.
That's what I
right?
was thinking.
Yeah, because
So-
how would you know then what
Exactly.
the normal range of motion is to themselves?
So you'll do two tests then, like.
You'll
one
do
with
both
the
feet.
one supposed injury and then one with the, not injured?
Yeah, so
Okay.
then, come back on your sit up. So then I would probably go, like in real life, if I was going to do it all against active range of motion, I would say, can you bring both your feet up? Okay, relax. And then if he was on his side, he would invert one and evert the other.
Okay.
And then
Gotta make
I
it
would take,
faster.
I would take note of that, and then he'd be on his stomach, and he'd plantar flex both, and then he'd finish that roll, and he'd do the other range of motion for that. Cool?
Cool.
And then passive range of motion for this too. So you did active range of motion, bring both your feet up. Okay, relax. And then there's no real specific hand placement here, just do it for them,
Mhm.
right? So active, they do it themselves. Passive, you do it for them. Okay?
Mhm.
Cool. And each one of the positions, just give them into that full range of motion. Cool?
Yeah.
So nothing crazy there. So just make sure you do all four of those motions or directions. You know, or you accurately state which motion is which. And you perform all of them against gravity. And you'll get full points for that. Cool.
What was it for this document?
It's the
Sam
Sam
splint.
splint, but we'll go over that. Because I just have a couple, so
Arm splint.
I want you guys to be able to practice everything and then take turns using it.
Are we being tested on arm sprinting?
The Sam splint, yeah, you will. I'll go over that after these ones. So we're good on active and passive. Now, your specific manual muscle test. Okay? So you're gonna put this down. So this is gonna be more, I'm gonna be very picky on your actual hand placement themselves. Okay? So let's say you're on their left leg. Yeah?
Mm-hmm.
So if you're using their left leg, you're going to be on the outside. This is how I start. You're going to be on the outside of them, facing your chest in towards their body. Cool?
Yeah.
Then the arm closest to their body is going to be above the malleoli, stabilizing the ankle. Yeah? And I'm going to have them bring their foot up into a dorsiflexion and in into inversion. So up and in. And you can even feel that anterior tibialis or tibialis anterior tendon kind of start to get really tense. So I'm going to stabilize here, and then I'm gonna resist him on my middle finger is going to be kind of aiming for that navicular bone. The navicular bone, you'll be able to find it because that's where the end of the tendon is, right? Cool. You can see it pretty good on him. I come up again and in. Yep. So stabilize here, close this arm, come from underneath, middle finger for that, aiming towards that navicular bone, and I'm gonna pull him in the opposite direction, right? So if the anterior tibialis does dorsiflexion inversion, I'm gonna pull him opposite, down into plantar flexion and into eversion, right?
Right.
So down and out. And how long do I do this for?
5 seconds.
Yeah, for muscle fiber
Muscle
recruitment.
fiber recruitment.
Yeah. Cool? Does the tibialis anterior. And then my next step, my little 4-step process, is going to be plantar flexion and inversion. Because the tibialis posterior is on the posterior side of the tibia, or behind the tibia, and it's also going to come down and attach to the bottom part of that navicular bone. So the anterior tibialis is on the top part of the navicular, the posterior tibialis is on the bottom part.
Okay.
So it's going to pull it down and invert. So I'm still holding my same ankle position, but now I'm coming from the top to the underneath. Yeah?
Mhm.
Still in that navicular area with my middle finger. Now I'm going to pull him up and out, right? Directly opposite of what the tibialis posterior is doing. Got it? Now, so I've done the anterior tibialis, posterior tibialis. Now I'm going to have him come straight out against me into eversion. Relax, relax. Try not to rotate your knee or your shin. So it's just move your ankle out this way. And I'm going to, and you can see his peroneals pop out here. See that? His peroneus brevis is going to attach to where? The base of the fifth metatarsal, yeah? So it's going to pull him just into eversion. So I'm going to push him into inversion. Right? But he's going to resist me as best he can. Got it? So this is pretty good. Like, I'm like 1, 2, 3. Yeah?
Yeah.
Then I'm going to have to switch all the way around. Sorry for the camera. Here, I'm going to switch the way my chest is going. Yeah? So the arm closest to his body is now going to be the one. So my opposite arm is going to be the one stabilizing the ankle. And I'm going to be testing his peroneus longus. So that's going to be down and out, right? The peroneus longus comes all the way down behind that lateral malleolus, goes past that base of the fifth to attach to the head of the first. So here, down and out. So this is called my thenar eminence, this meaty part of my thumb. I'm trying to match that with the insertion of the peroneus longus here at the head of the first. Yeah?
Yep.
So here and there, push down and out. So I'm going to push him up and in, right? Does that make sense? Push down, 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 down. Cool? And relax. Then you have those are the 4 kind of trickier ones, right? Because you have to learn which one plantar flexes, dorsiflexes, inverts, everts. Then the rest of the 4 are pretty easy, right? Bring your big toes up, or all your toes up. So I'm going to resist those 4. It's extensor digitorum longus. Just your big toe up. Extensor hallucis longus, right? And maybe come from back here. Flex your big toe. Flex your big toe down. Yeah, point it down. Flexor hallucis longus. Flexor digitorum longus. Cool?
Cool.
Not very hard, yeah. Those ones are really good. Really easy. Let's see. Right, you need to make sure you place the patient in the correct position. So for the anterior tibialis, you're going to place them in up and in, yeah?
Mhm.
And then you're going to have to resist appropriately. Because if you have them come up and in, but then you're like resisting them outside, that's not an appropriate test, right? You won't be testing the anterior tibialis. You're going to get all that stuff.
And with the specific manual muscle tests, we also need to be considering doing this against gravity?
Yeah.
Okay. Like, so we need to be having them on their belly or whatever for parts of this?
No, you can do it like this.
Okay.
Ideally, yes, but you're
Just
fine.
checking.
Yeah, you're fine.
Okie doke.
And I want you to, you don't have to do it as long as you state that you would compare bilaterally.
Okay.
So would you compare bilaterally, or we're saying?
We say that we would compare bilaterally
Okay.
Yeah.
in the instance of an actual injury.
And that it would be against gravity.
And that's what I'm hearing him say,
Yeah.
yes.
Okay.
That's a good point against the gravity thing with these specific manual muscle tests. These are all based out of Kendall.
Right,
And he just does them in these positions,
okay,
more for ease of the patient to execute these movements and your leverage against it.
right, and if you're
So some of
resisting them
can get kinda
anyway,
screwy. Right.
you're
You don't really
doing a whole
need-
lot more than gravity would anyhow, which
Yeah.
is why I asked the question.
Yeah. I theoretically, I guess the gold standard would be to find a position against gravity and resistance.
Right,
However,
to balance their comfort,
practical,
given that they're injured.
yeah, practical application, these specific direction or motions and hand placements have been developed.
Okay, cool.
That's fair.
So specific manual muscle tests, they don't have to move, they can just sit like this.
Yep.
Cool.
So now going into the special tests, right? So you'll have, right, so these are examples. I may not put these, I may put the other ones. Okay, so like don't just learn these two. So, the Taylor tilts, right? The Taylor tilts are gonna be where you just invert or evert, okay? So, if you guys recall, comes the other one. Your calcaneofibular ligament is shortened in a plantar flex position, right? It goes from here to here. Dorsiflex here, both your feet. Here, it lengthens.
Right.
So in a dorsiflex position, if you invert, a lot of your stability is coming from your calcaneofibular ligament, the CF. Cool? Versus, keep your feet dorsiflexed. Versus your, this is your anterior talofibular ligament. It's shortened in dorsiflexion, plantar flex. See, it gets lengthened. So put on tension in plantar flexion. So most of your inversion stability is going to come from that anterior talofibular ligament. Yeah?
Yeah.
And then inversely, the calcaneofibular ligament is shortened in plantar flexion. Got that? So knowing that, you can do the Taylor tilt, right? You're going to be on the inside of their body, facing the chest away if I'm doing this inversion test, stress test. So I'm going to come here, same, arm closest to their body is going to be stabilizing. The other hand, you're going to make a little bowl with your hand and cup the calcaneus. Your forearm's going to be on the bottom of their foot. And then you're going to just be a little lateral too, to gain some traction. And then you're going to, see I'm in a plantar flex position here, so I'm stressing that ligament there. This is pretty good. I would expect him to not have too much ankle trauma here. If I want to do more, so that's more for the anterior talofibular, right? If I want to do more calcaneofibular ligament, I'm going to have them dorsiflexed. Relax, relax. This is why I need my forearm here, because I'm in a dorsiflex format. Yeah? So relax, and then I'm going to come relax, 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 relax. In, out like that. Cool? Got it? See, I'm like stressing it, so I'm lengthening that calcaneofibular ligament as much as I can to see how much pushback I get or resistance from it. I'll show you guys again here. Can I take your shoe off?
Yeah.
So in a plantar flex position, here, ball. Make a bowl on the calcaneus here. I'm gonna be a little lateral to grip, and then I'm gonna come out like that. The ATFL, and then it shortens here. This is passive for him, so I bring him up manually, and then I'm gonna come out like that. Maybe it seems like he has more range of motion here. So that's gonna be the Taylor tilt for inversion for the CF and the ATFL. Yeah. You can also do the Taylor tilt for eversion, which is going to test the deltoid or the inside ligament. Yeah. And that you're going to have to be on the outside of them. So again, arm closest to the body, holds stabilizes the ankle. Same kind of thing as you hold with the bowl of your hand on the calcaneus, forearm on the bottom of that foot. But now you're going to go medially, and then you're going to come out this way. Doesn't really matter too much if you're going dorsiflex or plantar flex. Cool. So let's do this again this way. All right, on the closest, here, and then a little in. And I'm really trying to isolate those ligaments. And you feel that much stronger resistance there. Cool?
What's that ligament for you testing?
I just tested here. So the deltoid ligament is going to be the ligament preventing eversion.
Right.
Okay? So that's what I'm testing with this eversion talar tilt. Talar referring to the talus. Yeah? Also, you have an anterior drawer, or like think of like a dresser drawer and you're pointing towards you, or anteriorly. So you can have that in that dorsiflex or plantar flex position. So you can go here, same kind of hold as you would the talar tilt, but instead of coming into inversion and eversion, you're going to go towards yourself like that. So it also gives you a little bit of stability test. And then you can dorsiflex it, relax, and then come up too. See that? So here, instead of going in, you're going to come up towards yourself, and then you can do it in a dorsiflex position too. It's a lot more stable in a dorsiflex position. Cool? So a few different ways to test for that. Also, you have a high ankle sprain. Test what is damaged, what structure is damaged, ligament and associated structure is damaged with a high ankle sprain. That's right, you have your calcaneal, your low is your calcaneofibular ligament. Then you also have your anterior talofibular ligament. And then you have what up here? What are these two bones?
The tibiofibular.
So it's the anterior
Tibiofibular.
ligament up higher. And then between those you have a sheet of paper, thin like connective tissue called your syndesmosis joint, or your syndesmosis tissue. Okay? So that would be, if you get damage to that syndesmosis or the anterior tibiofibular ligament, that would be considered a high ankle sprain. And how you test that, you're going to come off the table just so your knees are hanging out. Yeah. So same thing, now my chest is facing in again. Kind of stabilizing his knee here. And I'm going to have to get a little low. So down here in that same position, holding the calcaneus and forearm under his foot. I'm going to come a little medial too, towards his big toe. And I'm going to bring him up into dorsiflexion, and then into external rotation. Okay? Because, go to the skeleton here for a second. The talus is way in the joint, right? Its most close packed position is in dorsiflexion, right?
Right.
So then when you dorsiflex and then you externally rotate, your external rotation puts pressure from the talus onto that fibula, and it causes a separation between the tibia and the fibula here. So it goes out like that. See that? See that visual? You guys see it? So dorsiflexion and then rotation. See the fibula is going to move away from the tibia here. Just like that. Cool? So that's called Kleiger's test. Kleiger. Kleiger's test.
That's for the high ankle.
That's for high ankle sprain.
You do that after you do all the others.
Yeah, probably that would be more of my last one.
Find nothing there, so now you're going up high.
Yep, exactly right. Also, you can tell too their location of pain. If it hurts here, here, or up top, or inside, right? If it hurts inside, probably deltoid. If it hurts outside on the bottom, probably calcaneofibular ligament. If it hurts kind of between the talus and the fibula, probably the anterior talofibular ligament. If it hurts higher than these two ligaments and maybe into here, maybe that tibiofibular ligament, the syndesmosis. Yeah. Also with Geiger's test, because you do get some external rotation, you may get some tension on that deltoid, on the anterior deltoid ligaments here. Yeah?
Yep.
So it doesn't exclusively, it doesn't exclude that deltoid, and it's not exclusively for that ligament. It's a little combination of the two. Okay? Cool? Then we'll go over Sam's point real quick. So you can have a seat, Nathaniel. All right. Thank you. Nothing against you, Nathaniel, but stash some hand sanitizer right there. So whenever you're going to splint an injury, you first you're going to check the integrity of their nerve and blood supply. Yeah? So nerves sense things, sense touch, and are responsible for motion. And then blood supply you can check via pulses, or let's say you have a fracture in your hand, what would you check? You can't check the radial pulse because that's too high up.
Fingertips.
Yeah, capillary refill, yeah? So you'd press on your nail bed, and then you'd release it, and you'd see the pink return. What if your athlete happens to have painted fingernails?
Or no, underside.
On the front.
Okay.
No, the
You do it on
pads.
your fingertips.
Yeah.
Yeah, you can turn it over, and then you see that, those capillaries refilling it.
So then why do we do it on the nail? Like, why can't we just do it?
It was just, they just thought of it first. And typically, you're in like that position when your arm hurts or whatever, so you don't want to like rotate.
If they were like,
Sure. I mean, adjust, adapt, improvise, and overcome to your every situation. Also, you wanna? So after you check pulse, motor sensation, what? No, you're just listening to the class. You're going to start forming your SAM splint. Yeah. So one of the first things you're going to do is you're going to create a little hand roll. Yeah.
Wrist.
So your hand is going to rest neatly on that. Yeah. Then let's say his right tibia or fibula is fractured. We want to stabilize. We're going to form it loosely to the left one. Yeah. Because you don't want to make any more injury than you have to. So here, and I'm just gonna like, basically form it, right? Obviously, you have a little bit of different contours from your right to your left. This is good enough. So then here, hold on to that, and then I usually instruct them to hold the bottom part here, and then we're gonna apply a spica wrap. Okay, a spica wrap is it's a way to apply the base bandage, and then you'll see this uniformed X pattern start to happen, and that was going to ensure equal pressure from distal to proximal. Okay, so here, there. So I'll show you guys. So spica pattern. You're gonna start unrolling your A strap on this bottom side. See that? Like this.
Yeah.
This, if you turn it upside down, this is wrong. See how it unrolls from the top now?
Yeah.
That's going to cause really awkward pressure, and you're not going to get a good gauge on it. So, the back side of it. Okay. Now I'm going to go from lateral to medial. Technically not, but I guess I'm going to go from pinky side to thumb. I'm going to go towards the thumb always with this. Cool? I'm going to go here, and then I'm going to come back up.
is it technically not because usually it's like this?
Because anatomical position is this, not this. So I'm going to come around like that. And then this extra part is a dog ear, we call it. and you're gonna flip it over to help lock that in place. Okay? And you're gonna come down again. Because remember the first one I went down, and the second one I came back up this way. So now this, the third one, I'm gonna come down, and then I'm gonna come up like that. Then I'm gonna come down. See what I mean by down? It's downward direction. And then come back around, I'm coming in an upwards direction towards the body. See that? And you see this pattern start to form. See that? These X's are called spicas. And then if I had more, it would keep continuing. See that?
Yeah.
Cool?
What would the X's at?
Here. Here.
Oh.
See that? You see that? Cool. I want you guys to know and verbally state that you would splint the joint above and the joint below the injury. Yeah? So if he has a ulna radius fracture or damage, you would splint
The wrist and the elbow.
maybe all the way, maybe a little further up on the elbow, and then the wrist. Yeah?
Mhm. Yeah.
Because you have muscles that attach to both of these bones from other extremities, right? We talked about that kinetic chain. One part of your body attaching and affecting the stresses of another part.
Mhm.
Yeah? So we want to reduce that stress and that opportunity for movement. Okay? You want to immobilize them as best you can. Cool?
Cool.
Alright. You guys are free to practice this stuff. I brought 2 A-straps and two SAM splints, and practice as much as you like till the end of class.